So without further ado, we're now going to launch into our first presentation, which is a verbal presentation, and it's by Dr. Andrew Wilson, Chair of South Cheshire Health.
Thank you.
Thank you, Andrew.
Right, thank you. This isn't going to be a long presentation, and I haven't got any slides. It's great to see so many people here, and I'm very pleased to be able to talk about South Cheshire Health. As I said, I don't want to give a long presentation. I just want to outline a few key areas, and I'm going to outline those really in quite broad terms, because after all, it's a question event, and so we shouldn't be talking and allow you to ask some questions. My big 3 areas I want to cover is I want to talk briefly about the health reforms and touch on some things which I think are misunderstandings or myths that are built up about some of the things that have been said. I think the media hasn't always represented things quite as I think they were intended by the people that wrote things down. I then want to talk a little bit about how GPs' involvement in commissioning might make things a little bit different. And then I want to talk about some of the big things that South Cheshire Health would like to achieve as it goes forward as a commissioning group. So going back to the health reforms and and this isn't a comprehensive review of the health reforms by any means, and I'm sure you're glad that I'm not going to give you a comprehensive review of the health reforms. It's just a few bits which I pick out that I think perhaps need some comment. The first is that there's been a lot of talk about this being revolutionary change, and there are things in the suggestions which are very different than they have been. But it is, I think, an evolutionary change, and it builds on policies that have been put in place before and policies that previous governments had. People have been trying to get clinicians involved in commissioning and in having a greater say in health services for quite a while now, so that concept is not new. I think an important point to say is that it's also evolutionary in the terms of the people who are involved. I think sometimes listening to the media you get the impression that there's 4 GPs sat in a room somewhere.
Sorry, I'm just sorry to interrupt. Because with the hearing loop going, there might need to be a team open.
Okay. Is that better?
Yes, that's much better. Thank you.
Where was I? I think sometimes the media gives the impression that the health reforms are about a few GPs sitting down in their practice meeting on a Wednesday morning and deciding how they're going to spend the £11 million that they've been allocated for their patients. And I think people worry that, well, what do GPs know about spreadsheets or accountancy? And anyway, if they did learn it, why are we wasting them doing that when actually they should be being doctors? I think I just want to say that it isn't like that. That yes, we have an input and we're talking to lots of people, but we've still got the experts. We've still got the experts in public health. We've still got experts in finance. We've still got experts in commissioning and in contracting. It isn't us trying to learn how to do all of those things. It's just us, given our perspective of how the system works, inputting into those people's work. So I think in those terms, it isn't as risky as it's sometimes been made out to be, but it's a bit of a maverick policy of allowing GPs to run away with all the money. Another aspect which I think sometimes is a bit confused, and I think it is difficult, and not all my colleagues, I think, get their head around this, is that I'm not here to represent GPs. I'm here as representing an organisation that is buying healthcare for the population. I'm here to represent patients and get the care for patients, not to stick up or to fight on behalf of my GP colleagues. That's for them to do, and that role is something separate and not something that I do. And that isn't easy necessarily to understand, and I don't think all my colleagues necessarily have quite got their head around it, but the commissioning group is for the benefit of the patients that it commissions for, certainly not for the benefit of one of the providers that it may commission, which would be GPs. Going a little bit on to how we might do things slightly differently. And as already said, evolution, not revolution. It isn't wholly different, it's a different perspective. Some of that is just we're clinicians and we see things happening on the ground, but some of it is, and there will be other clinicians involved, but a lot of it is about being GPs. I think early in a GP's training, they learn that there's lots they don't know. In fact, there's no way they're ever going to know everything that they need to know, and the only way they can actually get the care that they need for their patients is to work with the nurses that are in the building, the health visitors that are in the building, the hospital's doctors, with voluntary organisations, with the social worker. And so that is inbuilt into what GPs do. They know they don't know everything, they have to work collaboratively with others, and that is naturally our approach to commissioning as well. So when we're looking to buy services, we'll naturally go to our hospital colleagues and ask them what they think and how it should be done, or talk to a local authority about what the perspective is from the social care angle. And I think nearly all GPs learn that very early in their training and as newly qualified GPs. In the next few years, I think they learn an even more important lesson, which is the most important person you need to work collaboratively with is the patient. And I think that will also be at the heart of what GPs want to do as commissioners. And we do have the advantage that we do talk to our patients every day that we're in work. Now, some of us aren't in as work as much as we were a year ago, like myself, but every GP involved is still working as a GP 2, 3 or 4 days a week. So we still are talking to patients and still getting that perspective. What does South Cheshire Health want to achieve? I could talk endlessly, and I said that I won't talk endlessly, so I just want to pick out perhaps a few things. We want to build services around patients. There's lots of talk in health services about whether you should try to vertically integrate, which means integrate with your local hospital, or horizontally integrate, which means integrate across diseases, so that the person with diabetes and heart disease doesn't have to go to 2 separate clinics to have their care. That's horizontal integration. And I think there's a third answer, which is patient integration. You build the services around the needs of that patient. And that is what we would want to attempt to do in South Cheshire. So we want to build the services around the patient, and we want to build the services around that thing which is most constant in most patients' travels around the health service, which is their practice and their practice team of doctors and nurses, and we would hope to include in that social workers as well. And then those teams, those core teams, knowing the patient, calls in and gets assistance from, in easy ways, from the specialists that are needed. So an example of that, I think most times when we talk about these things, you think about a particular person. And the person I'm going to talk about is Albert. He is fictional, but he's a sort of a bit of a mixture of lots of people I've met over the years. So the illustration is to how things would be now and how we would like things to be different in the future. And they may be subtle, but we think they're important. So Albert is elderly. My example is deliberately about an elderly person, but in choosing an elderly person as my example, I want to point out that it's important that we don't forget about all the other things. I don't want to think that because I've chosen an elderly person, we're not interested in child health or teenage pregnancy or mental health or all the other aspects which are of great importance. So Albert is elderly. He's got several diseases. He has care that comes in, organised by the local, paid for by the local authority. The district nurses come in and dress his leg. He has a few falls, ends up in hospital. And when he's in hospital, he sometimes gets referred to outpatients clinics. And the scenario might be that Albert falls and he calls an ambulance and the paramedic turns up and the paramedic is caring and competent and he wants the best for Albert. And he doesn't think that Albert's hurt himself, and Albert doesn't think he's hurt himself, but somebody thinks, well perhaps he should be checked over in hospital. So he goes to hospital and he's seen by a junior doctor who is caring and competent and wants the best for Albert and thinks that their job is to admit Albert to hospital. So Albert's admitted to hospital. As a routine, Albert has some blood tests done, and one of the blood tests is a little bit abnormal, and so he's kept in hospital for a little while now. I, as his GP, know that that blood test has been abnormal for the last 15 years and is of no consequence. But it's new to the hospital doctor, so they hang around for a little while and they get a more senior opinion, and he's been in hospital for 4 or 5 days. And then the nurses, being caring and competent, want to check that his home environment is appropriate for him to go back to, and that takes another few days to be reassured of. And so actually it's 10 days later that Albert goes back home. Albert's a bit fussy about his eating, and even though the hospital food is perfect, he hasn't eaten very much. So Albert goes home a little bit poorer nutritionally than he was, and weaker because he spent 10 days in a hospital bed. He's worse off than he was before. Nobody has meant for him to be worse off. Everybody here has been caring and competent and wanted the best for him, but the system as a whole has meant that he's ended up slightly worse off. And just as importantly, somebody else or several other people have ended up worse off, because we've just spent a lot of money doing things to Albert that Albert didn't want and Albert didn't need, and therefore there isn't any money to spend on the next person who does need something to be done. So we hope to change that by getting stronger community teams, by delivering care closer to home, by improving communication between different sectors, by getting people to work closer together, by getting specialist advice more easily for GPs to get specialists to be working not just in the community, but in a community way and with community services. And none of those things will be particularly easy. And I suppose that's the bit I'll finish on, is that we've started to develop as an organisation. We've got ideas of where we need to go. We understand that there are a lot of difficulties along the way, not least of which that the country, the world arguably, is in a very difficult position with its finances, and that has an impact on everything that happens, including the health service, and that will make life more difficult. But we do think we've got a way forward, and we will battle hard to get there. I'm not sure that it will be quick, and I think a little bit of patience will be required for us to get things in place and to get things where we want them to go. That's all I've got to say.